In this section, we are going to discuss predominantly on the iron metabolism, on the basics of iron metabolism and a few of the iron indices as well. So the moment you talk about iron, you have to know about what are the types of iron existing in the body. Whenever I tell TBI, it means it's a total body iron. That's what it means. So what are the categories, what are the types of total body iron and how the total body iron is distributed in the body. So you can tell in two forms, you can tell the total body iron. One is what we call the functional iron. Second one, you can call it as the storage iron. So generally the functional iron forms approximately 70 to 80%, which I can tell it as 80%, and the storage iron generally contributes 20 to 30%, which I can call it as 20% by the principle. Generally storage iron are two forms are there. One is called the ferritin and second one is the hemosiderin. And the principal sites of storage for this storage iron is the liver. That's where the storage iron is stored. And if you ask me about the functional iron, the functional iron is distributed in many ways. For example, the most important and the major, a thing that carries iron in the body is the hemoglobin. You all know that, which carries approximately 65 to 70% of the total body iron. And you have myoglobin, which carries the 3.5 to 4% of the total body iron. And similarly, you have something called this heme containing enzymes, which are still going to contribute approximately 0.5 to 1% of the total body iron. So heme containing enzymes in the sense you have a lot of cytochromes, you have a lot of catalases, peroxidases, your flavoproteins, all these things do contain a heme iron. So that's why this is, first of all, this is really very, very important. And if you ask me the total body iron, so what is the total body iron? In numerical, so numbers. Total body iron. See, we have seen the qualitative distribution and now we see the exact quantitative total body iron. So typically if you ask me in females, it's approximately somewhere around 2 to 6 grams the total body iron, but approximately you can take it as 3 grams the total body iron in the body. And in males you can take approximately, it's there around 4 to 8 grams, but approximately you can take it as 6 grams. So this is the average number, not the exact number for the total body iron in the body. So once you know the total body iron, you have to know the next important thing, that is the your iron absorption and iron sources. So if you ask me how much is the recommended dietary allowance, that is RDA for iron, it's approximately 10 milligram per day. 10 milligram per day. This is the standard recommended dietary allowance for all the age groups. But even though there are some special age groups which need more iron, but this is the standard requirement, apart from the special groups. So which means if you ask me, out of 10 milligram per day, how much it's absorbed, if you ask me, it's only 10%. Only 10% on an approximate average is absorbed. So which means only 1 milligram per day is actually absorbed and remaining 9 milligram per day is actually lost. It's not going to get absorbed at all. So which means why this 1 milligram per day is needed? Because this 1 milligram per day is needed to compensate for the losses. This is a very tightly regulated mechanism. So this 1 milligram per day is absorbed to compensate for the loss, which means the loss is going to be approximately 1 milligram per day from the body. The loss is going to be approximately 1 milligram per day in the body. So where are the losses going to happen? The losses may happen typically from blood loss. If you ask me single most important reason for an iron deficiency, I would suggest it's a blood loss. And many people do tell it's a nutritional reasons, but I don't think it's a nutritional reason in the first place. It is the blood loss that tends to be the most important in the first place. I don't think nutrition doesn't make any sense at all in the first place. The reason is getting this 10 milligram per day is extremely simple. It's not that difficult at all. Even any diet if you take, you're going to get the 10 milligram very easily. But when you are losing extra, that's where the problem is. So this blood loss is very important, but this blood loss does not happen under normal circumstances. So does not happen under physiological circumstances except for certain pregnant population. Usually does not happen except for certain pregnant population. The next thing, Your loss may be from your urine, feces, and a little bit in the sweat, which is actually fixed and finite, and which is approximately equivalent to 1 milligram per day, 0.5 to 1 milligram per day, which means this is what is going to be fixed, this is what is going to be completely fixed, and this loss is something standard for every single age group. All the age group is going to lose 0.5 to 1 milligram per day in the urine, feces or the sweat. So to compensate for this loss only, you are having this 1 milligram per day. I mean, to compensate for this loss only, you are actually absorbing 1 milligram per day, because 1 milligram per day is lost fixed in the form of urine, feces and sweat. But to compensate for that, you are absorbing that 1 milligram per day. But this blood loss is something additional, which means if additional blood loss is there, you might have an additional, a loss of iron from the body, which means you might be needing an additional RDA, possible in special population. Or a second kind of population where they lose to some growth related purposes. For example, it's not the loss but the extraction. For example, if you have increased extraction of iron, so who's going to increase the extraction of iron? You cannot tell exactly to the loss, but there is something in the body that increases the extraction of the iron. For example, the fetus of a pregnant woman. So in pregnant females, again the risk of iron deficiency is very high, because the fetus is going to absorb a lot of iron from the mother and is going to deplete the stores. That is the reason why a pregnant woman again might need extra RDA, that is to compensate for the loss. At the same time, third thing, especially when the adolescent population is having a rapid growth, that time your tissues itself may be needing a lot of iron to rebuild your enzymes. So that is the time again you might be needing extra RDA, so that you might be compensating for this extra bit of loss that is happening within your body, which means they are extracting. So if these three things are not there, you don't have the blood loss and you don't have increased extraction related reasons, normally your loss is going to match your absorption, which is here. Your loss is going to match your absorption. So how much you are going to lose, the absorption will match it. Usually, typically this 10% applies only for people who are having moderate amount of iron, at the same time where the fixed losses only happen, where the other losses are not encountered. So this 10 milligram per day, 1 milligram per day absorption, 10% absorption overall, and 1 milligram per day loss, all these things you can say only if there is no additional losses or increased extraction. In fixed forms, this works perfectly fine. But I told you, in a lot of special circumstances, you might be needing extra iron because you are losing extra. Maybe in the form of blood, or maybe to the fetus, or maybe to the growth spurt, you might be losing an extra bit of iron. So you need an extra RDA in these purposes. So what are the conditions? First thing, I typically told you, it's a pregnant woman where they may be needing even up to 27 milligram per day. 27 milligram per day of iron may be needed. That is the reason why we give iron and folic acid tablets routinely to the pregnant women. Second area where you can see is a menstruating female. Any menstruating female, they might be needing up to approximately 18 milligram per day of your RDA. That is because they are going to lose every month. Every month the iron is going to be lost in the form of blood in the menses. So that is also very important. The third, typically in the adolescent population. In the adolescent population, again this is very important, because in the adolescent population, if you ask me, typically in the 14 to 18 years age group, the female population may need up to 15 milligram per day, and the male population may need a little extra, that is 11 milligram per day, for the growth spurt and the growth of the tissues in the body because of the action of the other hormones. So these are the three areas that you have to remember where you need an extra RDA to compensate for the extra extraction and extra losses. So which means if normal homeostasis, your RDA is in equilibrium with your absorption, which must be in equilibrium with losses. I am not telling RDA is equal to absorption. RDA can never be equal to absorption because your only 10 or maximum 20-30% of iron will be absorbed, but average is 10%. Should be equivalent, which means it's different. It means they are in the balance, and your absorption must be equivalent to that of the loss. Should be in equilibrium with that of the loss. So which means so that it matches whatever RDA you take, it should match the loss. And in between, your absorption is going to determine how much iron is absorbed, and this also plays a very vital role. So these are the three crucial factors that you have to know in iron homeostasis: RDA, absorption, as well as the loss or distribution of iron in the body. So this is what is going to happen. So this is the RDA. And next thing, whenever you think about your sources of iron, so what could be the sources of iron? Source of iron can be from two sources. One is from animal sources, that is typically the meat, where you're going to get iron in the form of heme iron. Heme iron, if you ask me what is the percentage that is absorbed, it is approximately around 20 to 30%, which means 20 to 30% of the heme iron can be absorbed, which is much higher than your routine average absorption, that is 10%. So heme iron is better absorbed. Better absorption happens with heme iron because we have separate heme transporters, which we'll discuss in the subsequent minutes. Then you have the plant sources. Plant sources typically have non-heme iron. The absorption of the non-heme iron is going to be very pathetic. It's only 2 to 5% of the non-heme iron will be absorbed, which is very little, which means non-heme iron generally has a poor absorption. But to an extent, I mean, there is no factor that determines the heme iron absorption, but there are a lot of factors that determine the absorption of a non-heme iron. At the same time, if you ask me what are the plant sources, you have a lot of fruits, you have vegetables, you have grain products like cereals, all these things, you're going to have a lot of non-heme iron. But most importantly, what are the factors that determine the absorption of non-heme iron? You can tell what are the factors that increase the absorption of non-heme iron and what are the factors that decrease the absorption of a non-heme iron. If you ask me what are the factors that increase the absorption of a non-heme iron, the first thing I'm going to tell is in the ferrous form. Ferrous means Fe2+. Similarly, because the DMT can directly transport. But the problem is if you have a ferric iron, where the non-heme sources are typically what? Ferric iron. Majority of the non-heme sources, most non-heme iron tends to be in the ferric form only. That is one problem because it has to be converted to Fe2+ to get absorbed back into the system in the GIT. So second thing, what is more important is the acids. Acids actually, they act as reducing agents, so which can itself reduce, your Fe3+ to Fe2+. So that is the reason why your acidic environment is again very important. For example, if you're having a hydrochloric acid or other reducing agents like ascorbic acid or vitamin C. This is also one reason why majority of the iron deficiency patients, while replacing oron iron, you also give vitamin C with it because it enhances the absorption of the iron tablets what you are giving. So that is the reason ascorbic acid increases the iron. So similarly, alkalis are going to definitely reduce the iron absorption because typically when you get an alkali, especially if the patient is using a PPA or if he's using a H2 blocker or if the patient is using for that matter, an antacid. Antacid itself is an alkali, isn't it? So this induces alkaline environment by reducing the acid secretion in the stomach, and this is going to cause alkalosis by itself in the stomach. So these are the two important things. Apart from that, your solubilizing agents. You have something called solubilizing agents like sugars, amino acids can increase iron absorption. At the same time, you have precipitating agents like phytates, tannates, phosphates, T, calcium. All these things are precipitating agents which can actually reduce the iron absorption. But solubilizing agents actually increase the iron absorption. Then you have ineffective erythropoiesis, can increase iron absorption due to many different principles which we are going to discuss later in thalassemia section. And you might have reduced erythropoiesis. So many people might get confused what do you mean by ineffective erythropoiesis and reduced erythropoiesis. Ineffective erythropoiesis means erythropoiesis happening, it might even be accelerated, but it is ineffective. The RBCs are not properly released out of the system because, or it's destroyed within the bone marrow, but the erythropoiesis is actually happening in an accelerated fashion. That's what I mean by ineffective erythropoiesis. Typical example is a thalassemia. But you ask about reduced erythropoiesis means the erythropoiesis itself is not happening. That's what it means for reduced erythropoiesis. Next thing, you have something called reduced serum hepcidin, which can actually increase the iron absorption. Similarly, you have increased serum hepcidin, which can reduce the iron absorption, because hepcidin is a direct inhibitor of iron absorption from the GIT, which we'll discuss later on. In detail, we have a lot of details which I'm going to share with you in hepcidin pathways in the next subsequent minutes, but just stay on. Pregnancy or other factors like hereditary hemochromatosis itself can result in increased iron absorption, because in hereditary hemochromatosis, again, the pathophysiology is due to reduced hepcidin. Because of that, you're going to have a increased iron absorption. Similarly, you have a chronic inflammation. Chronic or any inflammation can result in a reduced iron absorption, probably due to increased hepcidin, because inflammation itself is going to increase the hepcidin, because hepcidin itself is a positive acute phase reactant, which means inflammation itself will increase the hepcidin levels. Because of that, you might have a reduced iron absorption. These are the factors that favor iron absorption, or they may reduce the iron absorption, which is very, very important in knowing them. So after knowing this, the next thing is to understand about the iron absorption pathway. So this slide is definitely going to tell you a lot of detail on iron absorption. So you can see iron absorption happens in a lot of steps. You can see the first step in iron absorption. This is the first step in iron absorption, where we are talking about the non-heme ion in the first place. The moment you tell about non-heme ion, the one thing you're going to have is on Fe3+. This is the ferric ion. So you're going to have something called a ferric ion. So this ferric ion is converted to ferrous ion, that is Fe2+, by an enzyme called ferric reductase, which is otherwise called as cytochrome B. Obviously, like 3+ to 2+, loss of an electron is what we call as a reduction. So that is what we called as a Fe2+. Gain of an electron is what we called as reduction. Here one electron is gained, addition of one electron. That is why your Fe3+, which is more positive, becomes Fe2+, which is less positive because addition of the negative charge. So gain of electron, I told you, it is a reduction. So this is done by this enzyme called ferric reductase or cytochrome B. So once it forms this Fe2+, this Fe2+ is going to get absorbed into the enterocyte by a very, very important transporter, which is called as DMT1, that is called divalent metal transporter 1. As the name suggests, DMT1 is not only going to absorb iron, this can also transport copper, this can also transport zinc, this can also transport manganese, this can also transport cobalt, and this can also transport cadmium and lead as well, which means any divalent cation can be transported by DMT1, this divalent metal transporter. So the fate of the ion that came inside, so the ion has come inside, the fate depends on a lot of factors which we are going to discuss. So let us see what are the other ways for ion to come inside. So the second step tells you about the heme ion. So how the heme ion is going to come inside. So if you ask me how the heme ion comes inside, answer is really we don't know how the heme ion comes inside. It's going to come in the form of hemoglobin only from the meat, what you are eating. So you have something called HCP1, but probably we really don't know that this is the real reason or not, but we believe that this HCP1, that is called hemoglobin carrier protein or heme carrier protein 1, this is what we call HCP1, this is the one that is going to transport, probably, yes, going to transport this heme into the cell. You know very well, the moment the heme is transported into the cell, it's going to be acted upon by heme oxygenase, it's going to rip apart the iron separately, and it's going to give rise to biliverdin and carbon monoxide, so which you have seen already. And obviously this biliverdin will be further converted to bilirubin by an enzyme called biliverdin reductase, which this bilirubin will be further handled by the liver, which we see in the hepatology section. Okay, fine. So now there's a third source. I mean, this is something not given in a lot of textbooks, but still there's a third source that is called a ferric ion, which can be directly absorbed. There's a direct absorption of ferric ion, but in this process I told you ferric getting converted to ferrous and then getting absorbed, but there is some evidence, this is not very efficient technique, but still there is some evidence to tell that the ferric ion also can directly enter into the enterocyte using an integrin called integrin beta 3. So very important, maybe a future question in your exam. So integrin beta 3 mediates direct absorption of ferric ion, but to an extent. It's not an efficient way, but still to an extent this happens. But somehow you can see all this ion are reaching your enterocyte, cell in intracellular portion, which means somehow your ion has been reached here. So what is the fate of this ion? The fate of this ion depends on a lot of factors. For example, inside the cell, your ion is transported, which means this is for intracellular transport. This is for intracellular transport. Your ion is transported within the cell by a very important transporting agent. This is for intracellular. Extracellular, outside in the blood, it is transferrin. You always have to know about that. Within the cell, the ion can be transported. This is a new thing that is coming up, that is called something called a mobiliferin. That's what we're going to talk about. It's called a mobiliferin. So now, once you have this mobiliferin transporting within the cell, the fate of this ion. So if you ask me about the fate of this ion, the fate of this ion may have two different fates. So fate number 1. So I'm going to talk about fate number 1. Fate number 1 tells you this ion can be stored inside the mucosal cell itself in the form of ferritin. Or fate number 2, this ion can be transported outside the cell. Fate number 2 is outside the cell. It can be transported by a very important transporter called ferroportin. Or it can be this is fate number 1, which is stored within the cell. This is intracellular in the form of ferritin. Or fate number 2 is it's going to go outside the cell again with the help of a protein called ferroportin, which is on the cell membrane, on the basolateral side. You have to know very well. Ferroportin is on the basolateral side. Very important. So what determines whether there will be fate 1 or fate 2? Very simple. It depends on the hepcidin levels. That's why hepcidin is very, very important. It's a central molecule that regulates the ion homeostasis in the body. Very, very important. So if you ask about how hepcidin determines, so for example, if you have let us put it 2 different colors, maybe if you have a high hepcidin, for that matters, whenever you have high hepcidin, which means you're going to have a high circulating ion. Whenever there is a high circulating ion, this is directly going to stimulate your hepcidin release. So you're going to have a very high hepcidin. So in this condition where you have a very high hepcidin, so what is going to do is hepcidin is going to block the ferroportin. It's going to block the ferroportin in the first place, which means when you block the ferroportin, you are not going to transport outside the cell, which means your fate 2 is not possible. And only thing that is possible is fate 1, which means they are going to store the ion inside the mucosal cell of the GIT in the form of a ferritin. Why this is the case? You can see this is a brilliant thing that is happening. You can see whenever you have a high circulating ion, which means your stores of ion are very high. That's what it means. That's the reason why you have a high circulating ion, which means absorption is unwarranted here because you already have a very high ion. So it has to be stored within the mucosal cell in the form of mucosal ferritin, and it has to be shed. All this ferritin will be lost along the mucosa in the form of mucosal ferritin. As brilliant as that. So next thing you can see, second principle where you have a low hepcidin. When you have a low hepcidin, if you're going to have a low circulating ion. So whenever you have a low circulating ion, you are going to have a low hepcidin. This low hepcidin obviously it doesn't block the ferroportin. Instead, it is going to release the ferroportin from inhibition. So once low hepcidin releases the ferroportin from inhibition, you are going to actually follow the fate 2 than the fate 1, which means this is important because in a patient who's having a low circulating ion, you need a lot of iron that has to be transferred from the GIT into the blood because to increase the iron concentrations in the body. This is such a beautiful thing because ferroportin is under direct control of this bloody hepcidin, isn't it? So the hepcidin is the central molecule for iron regulation. We are going to learn a lot of things about hepcidin in the future. So, but still, right now, this is one of the very important basics of hepcidin. So the moment the iron comes out of the cell in the basolateral side towards the blood side, which means you are going to, because the Fe2 plus cannot be transported, to be honest, so it has to be oxidized again to something called Fe2 plus. You can call this ephastine as a ferroxidase because it's going to oxidize. Oxidize means it's a loss of electron, which means you remove one electron again, which means it becomes more positive, that is Fe2 plus. So it's done by ephastine, that's always called as ferroxidase. This ferric ion, this ferric form, oxidized form of iron is going to again, this is the one that is going to be carried by transferrin. Even though this diagram what I mentioned is not extremely accurate, but if you ask me, the transferrin molecule tends to be something like this. This is going to, the moment you add iron to it, for example, if you are going to add iron to it, to the transferrin molecule, actually what you are going to add is two ferric ion molecules. So you are going to add to the transferrin. Once you add iron to it, it forms something called a holotransferrin. Before adding iron, without iron, only if you have a transferrin molecule, that is what we refer to as something called a apotransferrin. The moment you add iron, there is, two ferric ions to the transferrin, because one transferrin can carry two ferric ion molecules, so that then you can call it as a holotransferrin. So this holotransferrin, other name is that is otherwise called as something called a diferric transferrin. This is also called as a diferric transferrin. So both are same. So this is the iron absorption and transport in the body. I think you have got it by now, how the iron absorption and the iron transport happens within the body. But now this what is going to happen is this transferrin is the one that is a major transport protein to a lot of different sites in the body. For the RBCs, for their proliferation, you need iron. For synthesis of hemoglobin, even in the bone marrow for RBC precursors you need. For cytochrome enzyme synthesis you need. The reticuloendothelial system needs iron for storage. For everything, the transport form means it is transferrin only. That's what is going to have transport, that's going to transport the iron to different areas in the body. But after knowing all these things, you can see how the iron is recycled. So this image is one image that's going to show the exact recycling of iron. So how the iron is recycled. So this image what I have given is a typical example of an RES, that is reticuloendothelial system, otherwise called as monocyte macrophage system. So monocyte macrophage system is per se a very big system which includes a lot of monocytes and macrophages scattered out throughout the body in different places, but we are not going to details about all those things. But what happens in the reticuloendothelial system? There are four processes by which the RES can get iron. The first way is through the senescent RBCs. The first way is through the senescent RBCs. These senescent RBCs undergo a process called erythrophagocytosis. Because of the erythrophagocytosis, this RBCs will be taken up and will be ripped apart. They will be ripped apart inside the erythrophagosome. And once the RBCs are ripped apart inside the erythrophagosome, you are going to push heme and globin. Obviously, you know very well this globin is going to degrade it further into amino acids, which can be further recycled. But what about this heme that is formed within the erythrophagosome? Yes, this heme is going to be again transported out of the erythrophagosome by a transport protein, which is what we are going to call it as something called a HRG. That's called heme regulatory protein, heme regulatory compound 1, or heme regulatory gene 1 and its product. That's a protein. HRG means heme regulatory gene. So that's going to transport, and once heme is outside the erythrophagosome, it follows the same principle which we have been discussing innumerable times. It's going to be acted upon by heme oxygenase, which is further going to convert into Fe2 plus biliverdin carbon monoxide. This biliverdin and carbon monoxide, further under the action of biliverdin reductase, is going to form something called bilirubin, which is further processed by the liver, which we have discussed innumerable times already. So now, once the Fe2 plus is formed, this is the iron is formed. Again, the fate of the iron, let us discuss, because this is only one source of iron for the macrophage or reticuloendothelial system. There are a lot of other sources of iron are also there. The second source of iron which I want to talk is coming from the transported form. So in the form of transferrin or holotransferrin or diferric transferrin. So I have drawn two Fe3 plus molecules here. So these are Fe3 plus molecules. I have drawn two Fe3 plus molecules bound to a transferrin molecule. That's why it's called a diferric transferrin or a holotransferrin. We have specialized transferrin receptors that is present on the cell membrane one, which is typically having high affinity for taking up transferrin. So this is what we call as a transferrin receptor 1, or like this is the one that binds with the transferrin and endocytose the transferrin inside. So endocytose the transferrin inside. So once inside the endosome that is formed, your Fe2 plus is further converted to Fe2 plus, which means they are going to reduce, which means this TEAP3 enzyme is going to do that here, which means this TEAP3 is somewhat similar to the the ferroreductase what you have seen, which means this TEAP3 enzyme is somewhat similar to the cytochrome B or that ferroreductase enzyme you have seen in the intestinal absorption of iron. So once this Fe2 plus is formed, it is moved out of the endosome and into the intracellular compartment of the cell and out of the endosome by again the same DMT1 which you have seen, that is called a divalent metal transporter number 1. So this is the principle that is happening. Apart from this, again once this Fe2 plus is pushed out, it enters the common ion pool inside. Similarly, if you have other ways of how to take the ion outside, so for example you have haptoglobin hemoglobin complex. Haptoglobin is going to trap the free hemoglobin molecules that is circulating in the blood. So free hemoglobin molecule generally do circulate a little bit, because normally itself some tearing of the RBCs might happen while passing into the circulation, so that your hemoglobin may be released in free form. This free hemoglobin is actually quite dangerous. Why it's quite dangerous? Because it can precipitate in the kidneys and can produce kidney injury. At the same time, since free hemoglobin even has more affinity for oxygen, so they can trap so much of oxygen, and they can, while passing through the circulation, they might cause a lot of oxidative damage because they carry oxygen along with them, and they get bombarded on the tissue. It's a free hemoglobin. Inside the RBC it's fine. If it's free, it's going to bombard a lot of surfaces and is going to cause oxidation related injuries because they carry oxygen. So free hemoglobin is dangerous. In normal circumstances, there is one important protein called haptoglobin that is going to avoid this free hemoglobin from circulating, so that it traps the hemoglobin, whatever it's released immediately, and it's going to push into the RES system. And RES has specialized sensing mechanism in the form of CD160, which transports the haptoglobin and hemoglobin complex. Similarly, this hemopexin is the one that is going to bind free heme. Note the point, it's free heme and it's not free hemoglobin. So once they sense this, this free heme is there in the blood circulating, by some reason your hemopexin is going to be trapping all this free heme. Trust me, this hemopexin is the only protein which has the maximum affinity for heme. If they ask you which protein in the body has maximum affinity for heme, answer must be this hemopexin only. So this hemopexin also can be sensed by a surface molecule called CD91, which is going to transport this hemopexin into the cell. This hemopexin into the cell, and it's taken up by the endosome. And finally, both this hemoglobin as well as heme is going to form ultimately heme molecules, which again transferred out by the same HRG1. Heme means outside this HRG1, transport outside, which enters the common heme pool. At the same time, they will be further converted to iron, biliverdin and carbon monoxide, where again this iron enters the common iron pool. Similarly, now you can see the intracellular iron sources is coming from 4 things. One is maybe by erythrophagocytosis, second maybe by transport form of iron, third maybe by haptoglobin hemoglobin complex, or fourth maybe by hemopexin heme complex. So these are the 4 sources of this Fe2 plus that is coming into the cell. So again, the fate of this Fe2 plus depends on, obviously your iron stores and epsilon levels. For example, again the movement of iron outside this RES system is mediated by the same ferroportin molecule. So which means, there are 2 fates. One is your fate number 1. So fate number 1 is followed if your ferroportin is blocked. If your ferroportin is blocked, your fate number 1 will be followed. When ferroportin will be blocked? If you have a high circulating ion, which is going to release a lot of epsilon, which is going to block the ferroportin, which means whenever you have high iron in the sense, which means they have to be stored in the form of ferritin, which means when you have a high circulating iron means it's a time for storage, not for putting again and again into the circulation and creating more problem. So this is what is going to happen. Similarly, when you have a low serum iron or low circulating iron, you will have a low hepcidin as a reflux, and your ferroportin will be released, and which means a lot of iron is going to be moving out through the portal into the circulation, which means in low serum iron states, you need a lot of iron released from the storage. So for example, whenever there is low intracellular iron, your ferritin itself can be mobilized to form Fe2+, which can again be mobilized to into the circulating pool, which means storage also can be sucked out from the RES in times of low circulating iron in the body. So these are some of the important things that you have to know. Once this Fe2+ come outside by some means, once this Fe2+ comes outside, it has to be further converted Fe3+, because for transporting again you need Fe3+, because Fe3+ only can be transferred to target tissues, because it has to be again transferred to target tissues, which means the stored iron can be taken out and it can be transferred to target tissues only again by transferrin. So again this transport is mediated by transferrin. And who's going to convert this Fe2+ by Fe3+ to Fe2+ to Fe3+? It's the ceruloplasmin, which is somewhat similar to your hephaestin in the GIT, or which is otherwise called as peroxidase. It is the ceruloplasmin is the one that oxidates Fe2+ to Fe3+ here, and this is the one that is very similar to the hephaestin and your otherwise called as peroxidase that we have seen in the GIT. So this is what is going to happen. This is how an ion recycling happens in the first place. So I told you about ion absorption and ion recycling. So the next thing what we can discuss is on hepcidin, because it's never complete unless and until you know the hepcidin. So that is going to be the main thing. So we are going to discuss on the hepcidin, because this is the cornerstone molecule for iron regulation. This is the one that is going to cause your iron regulation in the first place. So what is hepcidin in the basics of the hepcidin? So what is hepcidin? If you ask me what is hepcidin, first I'm going to call it as a hormone, or typically you can even call it as an iron regulatory hormone. Very important. This is the cornerstone principle for iron regulation, hepcidin. It has something called 25 amino acids. It also has a little bactericidal property. That is the reason it's called cidin. It is hepcidin because it has bactericidal properties as well. At the same time, which gene codes for hepcidin is the HAMP gene. That is chromosome number 19. You all know that even muscular dystrophy gene DMPK1, dystrophica myotonica protein kinase gene, is on chromosome 19. It's a very important chromosome. Similarly, HAMP gene also is present in the ever important chromosome number 19. So it is coming from the HAMP gene. So what is going to happen is hepcidin is like an iron sensor. It senses iron, more iron, circulating iron, more hepcidin, less circulating iron, less hepcidin. But how it happens is the key here. So at the same time, hepcidin is also considered to be one of the important positive acute phase reactants, which means hepcidin levels may increase with your inflammatory state. So hepcidin is considered to be one of the important positive acute phase reactants. And function of hepcidin is to block the ferroportin, which means this is a very important way to control your body's iron. So hepcidin blocks the ferroportin. So how hepcidin works is very simple. So you can put hepcidin is principally synthesized by the liver. So I can put a hepatocyte here. So hepcidin is going to be principally synthesized by the liver only. So I can tell this is an hepatocyte. In the hepatocyte, I can tell there are two things are there. You have transferrin receptor 1, and you can write TFR1, and you have transferrin receptor number 2. So remember, there is another protein within the liver, within the hepatocyte. This is called HFE gene product, otherwise simply referred to as something called HFE protein. So this is coming from HFE gene separately. It's HFE gene product. I'll tell you what is the importance of HFE gene product. Remember, both transferrin receptor 1 as well as transferrin receptor 2 are in competition with your HFE gene product, that is HFE protein. But remember, only when the transferrin receptor 2 is going to bind with HFE, it can activate the HFE. So I can put a different color for that. So only if the transferrin receptor 2, if it's going to bind with HFE, this only can activate the HFE. Binding of transferrin receptor 1 to HFE relatively has no effect on HFE. Which means HFE gene product or HFE protein cannot be activated whenever you have a transferrin receptor 1 binding with a HFE protein. So if you ask me, whenever you have iron adequacy, what happens? So let us assume in a simple terms, what happens if transferrin receptor 2 is binding with the HFE? Definitely HFE will be activated. Once this HFE is activated, it's going to activate a cascade. The first protein is going to activate is the something called HJV. You can draw a little bit big. That is HJV, otherwise referred to as something called a hemojuvelin. So once this hemojuvelin is activated by the HFE protein, this is going to dimerase with another protein called BMP6. This is going to dimerase with another protein called BMP6, that's called bone morphogenic protein 6, which is going to combine with each other. Once they combine with each other, they get activated as well. So once they get activated, so they're going to activate, the BMP receptor is nothing but serine threonine kinase, the types of receptors we've already discussed in endocrine system. But this is what we call SMAD pathway. This is going to activate SMAD pathway. Once they activate the SMAD pathway, they are going to activate the transcription of a gene called hampagene. These SMADs are going to activate the transcription of something called hampagene, whose product I already told you it is hepcidin. Hepcidin increases. So which means your TFR binding with HFE will activate HFE. Once it activates HFE, is going to activate hemojuvelin, BMP6, increase SMAD, increase expression of hampagene, and finally increase hepcidin release. So this is how the mechanism works. To activate HFE in the first place, you have to make the TFR2, that is transferrin receptor 2, bind with the HFE gene product. So these are some of the examples, classic example. So what you are going to see here is, the moment you have a very high level of circulating iron, if you have a circulating iron, means that also indicates you are going to have a very high level of transferrin saturated with iron. That is always referred to as holotransferrin, or otherwise referred to as dipheric transferrin. If your circulating iron is high, means itself you are going to have a very high levels of your dipheric transferrin. Once the dipheric transferrin levels are very, very high, so what is going to happen is they are going to saturate a lot of transferrin 1, because the dipheric transferrin's natural binding is on the transferrin receptor 2. Transferrin receptor 1. It's a natural binding site. Transferrin receptor 1 is a natural binding site for dipheric transferrin. So it's going to saturate all the transferrin receptor 1. The moment it saturates all the transferrin receptor 1, you're going to only have a lot of transferrin receptor 2 which is left free here. So which means transferrin receptor 2 is completely free here, because your high iron levels and high transferrin saturation is going to completely saturate all the transferrin receptors once with iron. So there will be no transferrin receptors that are free, because transferrin receptors are highly saturated with transferrin itself, and it is not free. Which means once it's not free, means it cannot extend any competition for the HFE protein. Now only left is the transferrin receptor 2. Now this transferrin receptor 2, no other option, it has to bind with the HFE, because there is no competition from transferrin receptor 1 now. So which will further activate the HFE, which will further activate HJV, causes BMP to come closer with each other, activate SMAD pathway, activate hampagene and high hepcidin. What you're essentially seeing is, whenever your circulating iron is high, you're going to get your high hepcidin expression. Similarly, whenever your circulating iron is high, you're going to get high hepcidin. So ultimately, this is the one that correlates with each other. Your increased circulating iron is going to correlate with high hepcidin release. Similarly, you can see what happens whenever there is a low circulating iron. You can see whenever there is a low circulating iron, what you can see in this picture is your transferrin receptor. Obviously, the equivalent of this is your transferrin saturation also will be very little. Your transferrin based iron also will be transferrin based iron. That is your holotransferrin also will be very much less, which means it cannot saturate the transferrin receptor 1. once it cannot saturate the transferrin receptor 1, you will have a lot of free transferrin receptor 1 inside the system, inside the cell, which can compete with the transferrin receptor 2 for binding with the HFE. So which means transferrin receptor 1 is going to now bind with HFE, and it will not allow the transferrin receptor 2 to bind with HFE, which means if you don't bind TFR2 with HFE, you cannot activate the HFE, which means HAV cannot be activated, BMP6 cannot be activated, SMAD cannot be activated, HAMGene cannot be activated, which results in very poor hepcidin expression. But the ultimate take home point is you have a low circulating iron and low iron stores, you are going to have a very poor hepcidin expression, which means your circulating iron and the iron stores and the iron load in the body is directly proportional to the amount of hepcidin circulating in the body. So this is how hepcidin typically regulates the amount of iron that is in the GIT. Like whenever you have high hepcidin release, high hepcidin expression, you're going to have two problems, because hepcidin, the basic function is to block the ferroportin. The moment you block the ferroportin, two things is going to happen. It's going to block the ferroportin in GIT, and it's going to block the ferroportin in the reticular endothelial system, which means in the GIT, it's important for absorption. And in the RES, this ferroportin is important for iron release from the cell. So the moment you block the ferroportin means you are going to block the GIT based absorption also. You are going to block the RES based iron release also, which means your iron absorption will decrease in case of high hepcidin. At the same time, your iron release will decrease, which means your storage iron might increase. Your storage might increase, which may reflect as increased serum ferritin may increase. Whenever you have a high hepcidin level, this is what is going to happen typically. So let us see some of the applied aspects in short. Well, maybe in 2-3 minutes we can see the applied aspects of this high hepcidin. So before going that, let us see what are the factors that influence hepcidin. The first factor that influence hepcidin is what are things that activate hepcidin, what are the things that activate or increase hepcidin, and what are things that inhibit or block hepcidin, reduce hepcidin expression. The first one is interleukin 6. Definitely is going to increase, because interleukin 6 is direct activator of HAMG. Because I told you hepcidin is interleukin 2 is a positive acute, interleukin 6 is a positive acute phase reactant. Similarly, your hepcidin is also a positive acute phase reactant, so both will be increased. Again, if you ask me, your hepcidin levels are directly proportional to the interleukin 6 levels. So more the interleukin, more the hepcidin, because both are acute phase reactants, as simple as that. So next thing what can increase is your erythropoietin. Erythropoietin can, whenever erythropoietin is in excess, it can activate the hepcidin release. This is happening through a different mechanism. So whenever you have a bone here, so let me draw a good bone. So whenever you have a bone here, you have, I already told you have something called colony forming unit erythroblast, which further differentiates into a pro-erythroblast, which further differentiates into many normoblasts, which further differentiates into a lot of reticulocytes. These reticulocytes are released in circulation, which becomes mature RBCs. So this is how it works. So I told you the erythropoietin's action is going to be maximally on the CFUE. So erythropoietin action is going to be maximally on the CFE. In response to this erythropoietin, the CFE release a compound called erythroferrone. This erythroferrone is a direct inhibitor of HAMP gene, which can directly inhibit or reduce the hepcidin release. So which means whenever you have a high erythropoietin, sorry for that, I should have put it here. Whenever you have a high erythropoietin, as a consequence, you are going to have a low hepcidin. So we can rub it here. So whenever you have a low erythropoietin, you can actually increase the hepcidin release. So whenever you have a low erythropoietin, which can actually activate or increase the hepcidin release. How this really works, this is the basic physiology which I've told you. So this is how it's going to work. Your erythropoietin, whenever it's in excess, you're going to have a low hepcidin. Actually, this is in a way, it's a simple physiology to understand. How you can understand this simple physiology is very simple. So whenever your erythropoietin is high means you need a lot of erythropoiesis going on, which means you want the CFU to be active, which means that is the reason why you want this high erythropoietin. That's an indirect signal. So whenever you want this erythropoiesis to go on, you don't want hepcidin, because hepcidin is going to block the iron absorption. So this, whenever there is low hepcidin, you are going to increase the iron absorption, isn't it? You are going to increase the iron absorption, which is actually needed for this erythrocytes that are proliferating more and more with the influence of erythropoietin. So when you have high erythropoietin, you will indirectly, like by a lot of mechanisms, you're going to have a low hepcidin. But at the same time, when you're going to have a low erythropoietin, definitely reverse happens. So you're going to have a high hepcidin. So similarly, when you have a high erythropoietin levels, or if the patient is having an active erythropoiesis, if the erythropoiesis is increased, you're going to have a low hepcidin as well. Similarly, other things that can inhibit the hepcidin release is something called hypoxia. Hypoxia can directly inhibit the hepcidin release, but at the same time, you can, as a beginner, you can remember hypoxia definitely will increase the erythropoietin. Because of that, you might have a low hepcidin. Then you have a very important enzyme called matriptase 2. So in this diagram, I have mentioned this matriptase 2 inhibits hemojuvelin. It doesn't inhibit, in fact, it cleaves the hemojuvelin. It's an enzyme that cleaves the hemojuvelin. So what matriptase does is, it cleaves the hemojuvelin, which means this signaling will not happen. This HFE signaling to HJV to BMP to SMAD to HAMP to hepcidin, all these things are disrupted. This entire signaling is disrupted because HJV is not functional. So your entire thing is completely disrupted, which means if this is disrupted, you can't get hepcidin, obviously. So there will be low hepcidin levels only. So these are some of the activators, and these are some of the inhibitors of hepcidin release. So these are the things that you want to know. But very important thing is the IL-6. So which you'll see what is applied in this. What is the applied in this? I mean, when you have a low erythropoietin, what is applied in this? And when you have a matriptase 2 deficiency, what is applied in this? And when you have mutations of HJV or HFE, what will be the applied in this? Let us see. So now you see what are the applied aspects in this. First thing, you can call in anemia of chronic disease. In anemia of chronic disease, what is going to happen? Or you can tell anemia of chronic inflammation. So in this condition, you are going to increase the IL-6 as a part of positive acute phase reactant. I told you the moment IL-6 is increased, your hepcidin levels are going to be abnormally high. Similarly, you have something called anemia of chronic kidney disease. In anemia of chronic kidney disease, you are going to have a inflammation also. This is CKD is an inflammatory state. Always understand. You're going to have a high degree of inflammation. At the same time, this anemia of chronic kidney disease may also cause one important thing, that is low erythropoietin, which you have discussed already. This low erythropoietin, I told you, it can also increase hepcidin by erythroferron mechanism, because you will have low erythroferron. Erythroferron is a very important blocker of hepcidin. So if there is low erythroferron, your hepcidin levels may be very high. So that is the reason your anemia of chronic kidney disease, anemia of chronic disease or chronic inflammation terminates in a common event called increased hepcidin release. So whenever you have an increased hepcidin, it's going to shut down the portal, which means they are going to inhibit the iron absorption in the GIT, as well as it's going to inhibit the iron release from the reticular endothelial system, which means your serum iron is going to be decreased a lot. And once the RES does not release iron, once the GIT does not absorb iron, the storage forms cannot be released for utility. At the same time, iron also cannot be absorbed. So there is a state of something called a functional iron deficiency. You're going to result in a state called a functional iron deficiency, not true iron deficiency, because it's because of hepcidin. It's not true deficiency. You have iron that you take a lot, but still cannot be absorbed, nor the storage forms can be released. So since the storage forms cannot be released, it actually appears as if the storage forms are increased. This is a paradox. Your RBCs are starved of iron. Your iron utilizing tissues are actually starved of iron, despite you're having a high store. So your serum ferritin may be normal or even increased, but what is going to happen is your your iron cannot be utilized, but anyway. So this is what we refer to as a state of functional iron deficiency. So I mean maybe normal or a increased ferritin is the norm here in anemia, chronic inflammation, or chronic disease. You can ask one more thing: inflammation itself can cause this high ferritin levels because ferritin itself is a positive acute phase reaction. So itself might increase in inflammation. So that principle is completely different. So I'm just telling. So this is the principle number one. What I'm seeing in anemia of Crohn's disease and anemia of chronic kidney disease. And the principle number two, what I can tell is based on your hereditary hemochromatosis. Your hereditary hemochromatosis may be due to two important principles. Number one, so here the problem is the HFE gene. If there is a mutation in the HFE gene. Typically two mutations are well known. One is called C282Y and second one you have something called H63D mutation, which I have discussed in detail in the liver hemochromatosis section. So the mutation in the HFE gene happens. Once you develop this mutation in the HFE gene, you're going to result in poor function, which means it's going to result in poor function of the HFE gene, which means you're not going to have HFE. So again, this pathway is disrupted. This HFE to your hemojuvelin to BMP6 to SMAD to HAMP to hepcidin. So this is the pathway. This is cascade that is disrupted because without HFE you can't produce hepcidin. Your hepcidin will be low. So once hepcidin is low which means it's due to disruption of the pathway, which means your iron sensing is lost. Your iron sensing is lost, which means hepcidin is not there at all, which is going to typically increase the iron absorption from the GIT. And it will be typically unregulated iron absorption in GIT, which means your iron is not at all going to be absorbed from the GIT. So once the iron absorption becomes completely unregulated, you are going to result in iron overload. And your serum iron, your storage iron, everything is going to increase. But this iron overload cannot be sensed. Sensing is lost. It cannot be sensed because of the mutation in HFE. This cascade is there because this is the pathway for iron sensing. It is disrupted, so if they cannot sense iron, they probably go for iron overload in the body. So this is the reason why a patient with a hereditary hemochromatosis may develop a iron overload state. Similarly, a patient with problems with hemojuvelin, this is what we refer to as something called a juvenile hemochromatosis. So if you have mutations in hemojuvelin also, you will result in the same iron overload picture again because this sensing pattern is the common thing. So again, this is disrupted, so it is not possible to have this iron sensing mechanism, and thus you develop an iron overload. Similarly, you have another last one. You have something called a matriptase 2 deficiency. Matriptase 2 deficiency. So whenever you have matriptase 2 deficiency, it results in a peculiar condition called something called iron refractory iron deficiency anemia. So what happens in this state is whenever you have matriptase deficiency, matriptase is the one that cleaves the hemojuvelin. That you can write as inhibit the hemojuvelin. When you don't have this properly working matriptase, you cannot inhibit, which means your hemojuvelin signaling will be more, which means this cascade is going to work more. You're going to increase the BMP6 signaling, which is going to increase the SMAD signaling, which is going to increase the HAMP gene expression, which is going to increase the hepcidin levels, which means your hepcidin levels are going to be abnormally high in this process, which is going to completely block the GIT iron absorption. Completely block the GIT iron absorption. So if you have a completely blocked GIT iron absorption, no matter, this patient is going to have a severe iron deficiency anemia, and it will be refractory to oral iron. It's not going to respond to oral iron at all because no matter how much iron you give, it cannot be absorbed because your hepcidin is blocking the portal for absorbing iron, that is the ferroportin. It's impossible to have iron absorption from the GIT. So this patient will not respond to any amount of oral iron. So completely refractory oral iron. So you have to treat these patients with high doses of IV iron, or in severe cases you might be needing blood transfusion as well. But apart from this is what we call as something called a IRIDA, or otherwise called as iron refractory iron deficiency anemia. So based on hepcidin you can plot a lot of beautiful things you can plot. So, but if you ask me what happens in an iron deficiency, the final nail in the coffin, if you have what happens in iron deficiency anemia, so what happens, it really is you have a low circulating iron, obviously because of the deficiency, you don't have proper iron. Obviously by a lot of signaling, I told you, it's going to reduce the hepcidin levels, which means the ferroportin are very, very active. That is why in iron deficiency anemia, actually the GIT absorbing potential, for iron is actually increased tremendously. Normally I told you average normal is approximately 10%, but in iron deficiency anemia it might even increase to approximately 20 to 30%, 2 to 3 times they might expand. That is because of the poor hepcidin expression in iron deficiency anemia, which can actually increase the absorbing capacity of iron in the gastrointestinal tract. So all these principles will clearly tell you how your iron absorption is typically regulated, and iron homeostasis is regulated by this hepcidin protein. So I think we can move on to the next one, that is your intracellular iron regulation. So whenever you think about your intracellular iron regulation, this is your intracellular iron regulating mechanism, iron sensing mechanism. How your intracellular iron sensing is based on two important things. One is you have something called an IRP model, that is called iron regulatory protein, which is present within the cell, and similarly you have something called iron response elements. And I mean, these are the mRNAs of certain proteins, and where the iron response elements are placed is what is going to be the key. So for example, for certain proteins, iron response elements are placed in the 5' region itself, where the beginning of the transcription happens. At the beginning of the transcription, such kind of mRNAs are ferritin and ALA synthase mRNAs, and at certain mRNAs where your iron response elements are placed in the ending of the mRNA, which means they are placed in the 3', near the 3' region of the mRNAs. Such mRNAs are transferrin receptor 1 and DMT1 related mRNAs. So what is the role of this iron regulatory protein, iron response elements? I mean, the entire cornerstone for understanding is where these iron response elements are placed. It's placed in the 5' or it's placed in the 3'. So suppose let us assume a condition where there is low iron. Typically, let me put in a different color called red. So in a condition where there is low iron, your iron response elements binding sites iron regulatory protein binding sites are actually free, which means once they are free and not bound to iron, because it's a low iron state, they cannot bind to iron inside the cell. So this free iron and free iron regulatory protein is going to bind with this iron response elements. They are going to bind with iron response elements, but in states of high iron, they cannot bind with this iron response elements. But in free, when they are not binding with iron, they can bind with this iron response elements. So when they are binding to this iron response elements, it can result in a lot of things. I mean, lot of things in the sense like it might result in a completely different scenario. For example, if the iron response element is in the 5' region, what might happen is, since it's located at the beginning of this particular mRNA, your translation may be completely blocked, which means your translation may not happen at all, which means you might reduce the ferritin and ALA translation in the first place, because this mRNA cannot be used for translation, because the translation will completely block in this particular mRNA. You cannot use this mRNA for translation because of the binding of the iron response element with the iron regulatory protein in the 5' region itself. The translation cannot move, it is blocked there itself. So it will result in reduced ferritin and reduced ALA synthase. This is needed because in low iron states you don't need a storage form, like only in excessive iron states you need storage. In low iron states you don't need storage, and you don't need to produce a lot of heme as well. That's the reason why your ALA synthase and ferritin is low. Similarly, since like this iron regulatory protein, this IRP is also binding with the iron response elements in different mRNAs at 3' site. When it binds to 3' site, your your result is going to be completely different, which means this mRNA is actually stabilized by this binding of iron regulatory protein to iron response elements at the 3' end, which means once the mRNA is stabilized, you are actually going to increase the translation of these mRNAs, resulting in increased transferrin receptor 1 synthesis and increased DMT1 synthesis, which is actually needed because in low intracellular iron states, you need to have high DMT1 to capture more iron. At the same time, your transferrin receptor iron and transferrin receptor 1 should be increased because they have to place a lot of transferrin receptor 1 on the cellular surface so that they can trap a lot of iron into the cell because it's a low iron state. That is the reason. Exactly reverse will happen when there is a high iron. When there is a high iron, what happens is the iron now is actually saturating the iron regulatory protein. Iron regulatory protein is now saturated with iron, so which means it cannot bind. So it cannot bind with the iron response element. So there is no binding with iron response elements, which means iron response elements are completely free. So it means once the iron response elements are free, in the 5' end, what is going to happen if the iron response elements are free? The translation is not blocked, so there will be increased translation of ferritin and ALA synthesis, which is again needed because in high iron state, storage should increase and heme production should increase. Similarly, if they cannot bind to the 3' end, iron in this condition, what's going to happen? The mRNA stability might decrease, which might result in reduced translation of this transferrin receptor 1 and DMT1, which is again the norm because already in high iron states you don't need that much DMT1 to trap more and more iron. So this is also one mechanism. This is very important for understanding how your iron is regulated intracellularly, or how your iron the various iron related proteins are regulated, the translations are regulated intracellular. These are iron response elements, iron regulatory protein model, which is very famous and it has a lot of proof as well for its importance. So now, after understanding so much about the iron metabolism, you can also know certain things on the iron indices. You can also note some important points about the iron indices. Whenever you think about this iron indices, so let me come back to this diagram once again. So you have something called, the first parameter is serum iron. If you want me to tell the normal values of serum iron, so serum iron normal values is approximately 55 to 160 micrograms per deciliter in a male, or it is approximately 40 to 150 micrograms per deciliter in a female, but average you can take it as somewhere around 50 to 150. This is how I remember. So I remember average of 50 to 150, like these values I marked it up just before the session. So but I do remember this is a very important number. So 50 to 150 is what I take normal, but to be honest, your serum iron is not that important comparatively. So because if you ask me what is the characteristic feature of this serum iron finding, so serum iron is actually very fluctuating. It it just reflects your recent iron intake. Your body might have an iron deficiency, but if you are taking a recent iron, excessive iron, your serum iron may completely be different. So it's fluctuating depending on your iron intake in the recent past, which means in the last 1 or 2 days, what is the iron intake? That's what is reflecting. It's not going to reflect a long-standing iron deficiency or probably even an iron overload. So it's not something very significant, to be honest. So it's not that important. And what are the conditions that increase the serum iron, and what are the conditions that might reduce the serum iron? The condition that might increase the serum iron is iron overload state. Typically, classical example is an iron overload, like hereditary hemochromatosis, or you have juvenile hemochromatosis, or chronic blood transfusions, which might load the patient with a lot of iron. So a lot of things are there. So whenever you reduce, what are the conditions that reduce serum iron? You can see in two conditions. One is called iron deficiency, where the iron supply via the nutritional pathway itself is very less because the demand may be more. Second thing, your anemia of chronic disease, where because of the high hepcidin levels, your absorption by the GIT as well as release of the iron into the blood from reticuloendothelial system is reduced. Because of that, your serum iron may take a hit. So these are the various things that you have to know. So now the second thing I can tell is ferritin, very, very important marker. Ferritin. If you ask me the normal ferritin, you tell 12 to 300 nanograms per ml in males, and I can tell somewhere around 10 to 150 nanograms per ml in a female. But average what I remember is 20 to 100, but some labs tell 20 to 200 also, but I remember only this. This is the one I told, as I told you, I marked it up just before the session has started. So this is the one that I remember forever, 20 to 100. This is what we see routinely in our practice, 20 to 100. So ferritin, is the parameter of choice in iron deficiency. If you ask me single best parameter of choice in iron deficiency, if they ask you single best parameter of choice, first thing to show a change and single best parameter of choice in iron deficiency patients, answer is always ferritin. But remember, one important pitfall is there. Ferritin is a positive acute phase reactant, which means the levels can be changed by inflammation. So that's what we're going to see. So what are the conditions that increases ferritin? Obviously, ferritin is a storage form of iron. Where your storage iron will increase is in iron overload. In iron overload, your storage form of iron is going to increase for sure. So, or in a sideroblastic anemia, again your ferritin might increase, because in sideroblastic anemia what happens is the iron utilization, we're going to discuss in the next section. So sideroblastic anemia, your iron utilization again will be reduced, because in sideroblastic the protoporphyrin will not be synthesized properly, which means iron is there but protoporphyrin is not produced, which means iron cannot come into the protoporphyrin to produce the heme. So iron will accumulate, and once intracellular iron is accumulated, it will result in increased ferritin synthesis, obviously, which I explained in the previous slide. So then you can get in megaloblastic anemia also. A lot of megaloblastic anemia. Again, why in megaloblastic anemia? That is because of the maturation of the RBC will not happen. Because of that, your iron utilization will be very poor. So all these things, but iron overload is very classic. Then condition that reduces what condition that reduces ferritin, in the sense your first answer should be iron deficiency anemia. If they ask you, again I told you single best, again one more point, it's earliest parameter in an iron deficiency anemia is low ferritin. And in iron deficiency anemia, this low serum ferritin is considered to be extremely specific finding than sensitive finding. It's a very, very specific finding. Even though there are pitfalls, the levels may be falsely normal or even increased in iron deficiency anemia if there is a coexistent inflammation going on. So you cannot completely rely on serum ferritin, but if the ferritin is low, 100% there is only one possible diagnosis, that is iron deficiency anemia, at least in real life. Maybe in exams you might have a lot of unnatural and rare theoretical cause like aferritinemia, but apart from that, I don't think there is another cause to substantiate apart from iron deficiency if there is a low serum ferritin. Less than 10 low ferritin is equal to iron deficiency in practice. That's it. It's very, very specific finding. So you might rarely get a low ferritin in a nephrotic syndrome, but these are only theoretical because of loss of ferritin in the urine, as simple as that. But apart from that, this is not that important. The third parameter I can tell you is the transferrin saturation. That's otherwise called as TSAT, transferrin saturation. What do you mean by transferrin saturation? Normal is 20 to 50% in males and approximately 15 to 50% in females, but again I remember as 25 to 45%, same as that of the hematocrit. That's how I remember. So 25 to 45% is a normal TSAT. So how you're going to calculate the TSAT is by taking serum iron divided by TABC multiplied by 100. Now you know what is serum iron. I introduced TABC, a new terminology that's called total iron binding capacity. That's what you mean by TABC. So come back to TABC in some time. So what are the conditions that increase the transferrin saturation? Again, you're going to get in the same principle, that is iron overload, and you can get in a sideroblastic anemia. Then you can get in a megaloblastic anemia. Same situations. Megaloblastic anemia. So in all these conditions, your TSAT may be high. And similarly, where you're going to get in iron deficiency anemia, or you might get in anemia of chronic disease, and similarly you might get in a nephrotic syndrome. I didn't tell you, again serum ferritin may be high. I didn't tell you, this one point is very important, because the serum ferritin may be high not only in iron overload state, even in anemia of chronic disease. Why in anemia of chronic disease serum ferritin is high? I already told you, in anemia of chronic disease there will be high hepcidin levels. Because of high hepcidin, the release from the RES will be, reticuloendothelial system will be reduced. Because of the release of the iron from the reticuloendothelial system is reduced, your intracellular iron within the RES will increase. They will start synthesizing more and more storage form in the form of ferritin. Plus at the same time, in anemia of chronic inflammation, ferritin itself being a positive acute phase reactant, it might be elevated. But that's what the difference here. Actually, the transferrin saturation will be decreased in anemia of chronic disease because the release is reduced. Obviously, the serum iron will be released. Serum iron also will be reduced in anemia of chronic disease. At the same time, your transferrin saturation will also be reduced. Which means, if you take iron deficiency anemia versus anemia of chronic disease, which I'm going to discuss later on as well, the major difference is here the serum ferritin will be reduced, where the serum ferritin anemia of chronic disease will be typically normal or increased. This is a very important finding. Very, very important. But remember, many times both may coexist together. How to find it, I'll tell you later on. But anyway, so this is a very important, as far as the exams are concerned, this ferritin is such an important entity. So that's why this TSAT is also important. So TSAT may be reduced in iron deficiency and anemia of chronic disease, but it will increase in iron overload states. But anemia of chronic disease may have high ferritin, but not TSAT. TSAT will be low in anemia of chronic disease. Then what about transferrin alone? If you take the transferrin alone, transferrin normal value is approximately 170 to 370 milligrams per deciliter. This is the transferrin that is circulating in the blood. So transferrin, it can be converted to TABC. What the important point is, it can be converted to TABC. Transferrin you can convert to TABC. So the formula for TABC is 1.389 multiplied by transferrin. So when you multiply this 1.389 by a factor of 1.389 to transferrin, you will get the TABC value. That is total iron binding capacity. Remember, this total iron binding capacity also dependent on the transferrin only. Simple. So the transferrin is the one that determines the iron binding capacity in the blood. So which is equivalent relatively. But converting needs some factors. That's it. So where you have a increased transferrin, so typically you will have an iron deficiency. In iron deficiency, you might have a increased transferrin. At the same time, in anemia of chronic disease and in iron overload states, you might have a reduced transferrin. Similarly, increased transferrin may be seen in conditions which increases the transferrin synthesis in the body, like for example, pregnancy and OCP. And in this condition, especially progesterone effect. Progesterone may increase the production of transferrin from the liver. Because of that, your total iron binding capacity in pregnancy might increase, and because transferrin levels might increase in pregnancy. At the same time, in nephrotic syndrome, similarly, your transferrin levels may be decreased. That is because of loss of the proteins in the urine in nephrotic syndrome. So these are some examples of decline in the transferrin. Then you have finally your hero comes, that is the total iron binding capacity. When I think about total iron binding capacity, the normal value is approximately 250 to 450 micrograms per deciliter. This is the normal total iron binding capacity. So whenever you want to know what is the TABC, either you can use the formula 1.389 into serum transferrin levels, or you can use the formula, one more formula, that is unsaturated iron binding capacity plus serum iron, which I'll explain you in some time. What is that? With the diagram, UIBC plus serum iron also gives your TABC, total iron binding capacity. And what are the conditions that is going to increase? The same condition what I have told for transferrin, and the same condition that I have told for decrease in the transferrin. That is going to, because the transferrin is the one that is going to typically result in a TABC, because the total transferrin levels, the transferrin is the one that's going to bind the iron in the blood. Definitely the transferrin is the one that going to it's one of the major factors that influence the TABC. Transferrin, obviously. So the same thing is going to be applied, the decrease and increase. I'm not going to tell something different. So then you have two special indices, which is most useful only for iron deficiency versus anemia of chronic disease difference. One is the soluble transferrin receptor, and next is your soluble transferrin receptor by, I can write spelling, soluble transferrin receptor, and second one is your soluble transferrin receptor by log of ferritin ratio. Before going into this, let me explain you the diagram first. You can see this is a beautiful diagram. I can put transferrin related indices on one side and iron related indices on one side, because both are almost same, because transferrin is the one that is going to bind the iron, obviously. So let me put on either sides. So I can tell, if you take the same thing, you can take in two ways. You can take this as a transferrin also. You can take this as how much iron is bound also, because iron in the serum and transferrin in the serum are something equivalent. So what I'm trying to tell here is, if you take this box as a transferrin, if you take that this box is a transferrin, so what happens is, how much iron is bound to the transferrin is what we refer to as something called a transferrin saturation. Similarly, how much iron is bound to the transferrin is what we are going to call as a serum iron as well. Yes or no? If you take in transferrin-related terms, how much iron is bound to the transferrin, we are going to call it as a transferrin saturation. How much transferrin saturated with iron. The same thing, if you tell in iron terms, how much iron that is bound to the transferrin is going to tell you that serum iron. Very simple. The same thing. That's it. The remaining part of the transferrin that is not saturated, if you tell it in the transferrin terms, means it's an apotransferrin, right? The remaining thing, if you tell in iron terms, remaining part of the transferrin that is not saturated with iron, you're going to call it as UIBC, that is called unsaturated iron binding capacity. Similarly, if you take the entire thing, that becomes a total iron binding capacity, which means the unsaturated iron binding capacity plus the serum iron. So this plus the serum iron becomes the total iron binding capacity. Similarly, your amount of transferrin that is, amount of iron that is bound to the transferrin becomes something called holotransferrin. And if you add this holotransferrin as apotransferrin, you are going to get the serum transferrin. As simple as that. So very simple. So if you have an entire transferrin, if you take the total transferrin, so this is the TIBC, which means is the total iron binding capacity, and how much it is bound, how much, for example, this is the iron that is bound with the transferrin, that becomes a transferrin saturation. On the other hand, that also becomes the serum iron also, because all the serum iron is carried through transferrin only. The remaining typically is going to become a UIBC, that is unsaturated. Remaining typically is going to become a UIBC, otherwise I can call it as unsaturated iron binding capacity. Similarly, the amount, in technical terms, if you ask me what is the transferrin that is carrying iron, that becomes the apotransferrin, and the remaining, what is not carrying the iron, becomes the holotransferrin. What is carrying the iron becomes the holotransferrin, and what is not carrying the iron becomes the apotransferrin, and the both things together will form the total transferrin. As simple as that. Now I think you will know what do you mean by transferrin, what do you mean by apotransferrin, what do you mean by holotransferrin, what is the total iron binding capacity. That's the entire transferrin in the blood. That is the one that is going to give us. And you can also see that the total transferrin is the one that is going to give rise to the total iron binding capacity, because these are completely equivalent to each other. These are the ones that determine each other. Transferrin is the one determining the total iron binding capacity. The amount that is filled with iron is what we call the transferrin saturation, which on the other hand will equate to the serum iron as well. So simple, everything is equated. That is why whenever you want to calculate the total iron, you want to calculate the transferrin saturation, it is the serum iron divided by total iron binding capacity. That will give you the transferrin saturation. As simple as that. That is why the transferrin saturation formula is serum iron divided by TIBC. Now if you want to know about the special indices like STFR, that is the soluble transferrin receptor. So if you want to know about the soluble transferrin receptor, the normal value is approximately 2 to 2.5 milligrams per liter in males and 1.9 to 4.4 milligrams per liter in females. So this is actually, ask me what is the soluble transferrin receptor. It is not the same as transferrin. Very, very important point. It is not equal to transferrin. It is the transferrin receptor that is cleaved from membrane. It is nothing but a cleaved transferrin receptor from the cell surface, from the membrane of the cells. It is the cleaved transferrin receptor from the cell membrane. And actually it is, what is the important thing about this is this cleaved transferrin receptor from the membrane is actually proportional to the erythropoietic activity. It's proportional to the erythropoietic activity, erythropoiesis, and it's actually inversely proportional to the iron availability. Which means if your erythropoiesis is increased, your STFR will increase. If your iron availability is low, again your soluble transferrin receptor will increase actually. So that is what is going to happen, inversely proportional to iron availability. So what happens, what are the conditions that can increase typically is in iron deficiency. In iron deficiency, the main problem is you're going to have increased iron availability. You're going to have low iron availability. That is the reason your STFR is increased. Similarly, in hemolysis, if you ask me in hemolytic states, your erythropoietic activity is increased. That is the reason your soluble transferrin receptor is increased. Number 3, if you ask me, in one more condition called after administration of erythropoietin stimulating agents, erythroid stimulating agents like recombinant erythropoietin or darbepoetin alpha or pegylated epoetin beta, a lot of kind of things are there which come under this ESA, that is erythroid stimulating agents group. Whenever you administer erythroid stimulating agents, you are going to accelerate the erythropoiesis. Because of that, once again your soluble transferrin receptor may be increased. But the most important thing is where it is decreased, it is in anemia of chronic disease. This is the most important fact, because in anemia of chronic disease, your iron availability is actually, inside the cell your iron is actually high. So we are talking about intracellular iron availability. Not only extracellular, intracellular iron availability. Intracellular iron availability is actually very high in anemia of chronic disease, but the serum iron is low because the release is poor. That's all. And because of that, in anemia of chronic disease, your soluble transferrin receptor may be very, very low. Similarly, in iron overload states, your soluble transferrin receptor may be low. But apart from that, in nephrotic syndrome, it might be low because of the loss in the urine. And similarly, in a condition called atransferinemia, where there is no transferrin receptor at all. So in this condition also, you might be having a low soluble transferrin receptor, because if there is no transferrin receptor, how it can be clean? So in atransferrin. But the most important is differentiating these two. You have to know that in iron deficiency, the soluble transferrin receptor will be increased. In anemia of chronic disease, the soluble transferrin receptor will be decreased. The final one is the soluble transferrin receptor and log ferritin ratio. So what is the most important thing in this soluble transferrin receptor and log of ferritin ratio? It is calculated by this only, soluble transferrin receptor measurement divided by the logarithm of ferritin ratio. So what happens is, in iron deficiency, the values will be more than 2, whereas in anemia of chronic disease, the values will be less than 1. Again, these two indices which I have told, the soluble transferrin receptor level and soluble transferrin receptor log of ferritin ratio, both are important for differentiating between these two things. That's why these two are important. These are very specific indices for differentiating iron deficiency versus anemia of chronic disease. Why I told you in the beginning itself, sometimes iron deficiency anemia and anemia of chronic disease may coexist together. May coexist, not always, but may coexist with each other. So in this condition, these indices might be of real help. Your soluble transferrin receptor and soluble transferrin receptor by log of ferritin ratio. If you ask me what happens in iron deficiency, why this ratio is affected. In iron deficiency, what happens? Your soluble transferrin receptor will actually increase. And if you ask about the ferritin, just put the log that is different just to reduce the number. So if you put ferritin, what happens in ferritin is decreased. So the entire ratio will increase. That's why the ratio is more than 2. But on the other hand, if you see in anemia of chronic disease, what happens to the soluble transferrin receptor? It's going to actually decrease, and actually the ferritin is going to increase. You can put log here. So the log of ferritin will increase, which means the ratio will automatically decrease, because the numerator is decreasing and denominator is increasing. The ratio will automatically decrease, which brings the ratio to less than 1. So that is the reason why this soluble transferrin receptor by log of ferritin is extremely important. So this is the net summary of whatever we have discussed till now. So we have discussed on serum iron, we have discussed on ferritin, we have discussed on TSAT, and we have discussed on your transferrin, we have discussed on the TABC, and we have discussed on the special indices for differentiating iron deficiency versus anemia of chronic disease, that is soluble transferrin receptor and soluble transferrin receptor by log of ferritin ratio. So I think that brings up the end of the coverage for your iron metabolism and related iron indices. So in the next section, we might be talking on your iron deficiency anemia and the other anemias that causes microcytosis, except the thalassemia. So we're going to discuss iron deficiency anemia, anemia of chronic disease, and the sideroblastic anemia in the upcoming section.